have no conflicts to reveal, and all studies were approved by either IACUC or IRB, and EPO is off-label for neuroprotection. Next slide. Our learning objectives today are to talk a little bit about extreme prematurity and why the preterm brain is at risk. We'll look a little bit at bench to bedside approaches to improve neurodevelopment. And finally, I'll talk about the results of the PENUT trial and learnings from that. Next slide. So prematurity occurs in almost 400,000 babies a year in the US, or 1 in 10 births. And most of these are the more mature preterms, but about 0.7% are 28 weeks or below. And at this point in time, over 95% survive. Next slide. Outcomes are dependent on gestational age, with the less mature babies doing not quite as well, as you can see here. The green bars show behavioral disorders, educational support, special healthcare needs, and disabilities are greater in the younger children. So just an overview of outcomes. Next slide. We see about 18% death, although it was 12% in the PENUT trial, and around 40% of these extremely preterm babies develop severe long-term intellectual or physical impairment. And you can see the breakdown there. So around 9% cerebral palsy, 25% intellectual disability, and so on. One thing that's not often considered as one of the major morbidities is behavioral and psychiatric problems that are diagnosed later. So about 10% of these kids develop autism. ADHD is quite common, as are psychiatric problems. Next slide. So why are these kids at such high risk? Well, the answer is, next slide, and if you can just click forward on these, I show here on the left a 23-week gestation brain as it develops to term. And then in the bottom panel here, you can see the development of neural complexity as you go from the newborn to adults. And now on the right, you can see the development of the cerebellum, which isn't often thought about, but it turns out it's really important in the development of neurodevelopmental outcome. Next slide. So the third trimester is supposed to be spent inside mom, of course, and instead, if you're born at 24 weeks or so, there's a loss of maternal and placental input, stress and pain, inflammation. There's neurodevelopmental disruption, nutritional deficiencies. The microbiome is altered because of our use of antibiotics. We give these babies sedatives, and their anemia is quite common, as are transfusions and or iron deficiency. Next slide. So this all contributes to disruption of normal development, and microglia are often activated, and these cells are important for synaptic pruning, inflammation, and tissue repair. The neurons are affected, and we often see abnormal dendritic arborization with the resulting abnormal connectome. And as we all know, oligodendrocytes are affected, and that affects myelination. So there's also damage to existing structures with intraventricular hemorrhage or periventricular leukomalacia. And I'm always impressed that despite these things, over 50% of these babies develop normally. And I think that's an important point for us to consider when thinking about what provides resilience in these babies. So this next slide is a slide about going from the preclinical to clinical trials. And basically, these are the stages of discovery, with starting at stage 1 with basically some discovery. It's explored further, usually in cell culture or rodents in stage 2, and confirmatory studies are done in larger animal models, and then it goes to clinical trials, with phase 1 being primarily feasibility and safety, phase 2 being safety and a little bit of efficacy, phase 3 are larger studies focusing primarily on efficacy. Next slide. So it's really all about mentors, and this is a little bit of my history. When I started fellowship in 1986, I really just wanted to be a clinical neonatologist, but doing research was part of the fellowship. And over the 3 years, I began to understand the importance of research, and really started to want to contribute to moving the field forward through doing research. In 1991, I moved to the University of Chicago, and shown here is Nancy Schwartz, who was the head of graduate studies, and I undertook a PhD and learned about how to do research. I then moved to the University of Florida, where Bob Christensen really helped me to understand how to make research fun and inspirational. And finally, when I moved back to the University of Washington, Chris Gleason was my division head, and she was famous for saying, basically, focus. You have to focus on one thing to answer a question. You can't do necrotizing enterocolitis and brain development. So these are the people that really helped my career. And next slide. You never know where life will take you. It's really a long and winding road. Next slide. So I began my studies of EPO in the mid-1990s, when Bob Christensen came to me with this study that functional EPO receptors were present on cells with neural characteristics. And if you can click forward, this was followed by another paper showing that astrocytes actually produced EPO. So I became very interested in this. Next slide. So EPO is primarily produced in the liver during fetal life, and then in the kidney in postnatal life. And its primary duty is to promote erythropoiesis. So it decreases apoptotic cell death of red blood cells and then promotes the maturation of these cells. Next slide. In the brain, EPO is made in astrocytes, and there are several cells that bear the EPO receptor. And click forward. So these work basically similar to what it does in bone marrow. So if EPO is present, these cells have a better chance of survival, and in the absence of EPO, they're more likely to undergo apoptosis when faced with adverse situations. Next slide. I'm going to quickly go through some of the preclinical work, because I think we've lost quite a bit of time. So this was a study done by Eric Demers looking at EPO neuroprotection in rats and showing that EPO actually was protective. Next slide. This was done by Brian Kellett, looking at what dose, how often, again in a rat model, looking at 1, 3, or 7 injections and various doses as shown here. Next slide. He showed that multiple doses were most effective, and our best dose in rats was 5,000 units per kilo, 3 times for 3 times after injury. Next slide. One of the concerns about EPO at the time we were doing this was that it increased ROP, and in thinking about the use of EPO for preterm infants, this was a big deal. And so Jessica Slusarski, who was a fellow at the time, developed a rat model of ROP and showed that EPO did not increase the risk of ROP when used at the doses we were using. Next slide. So just to summarize the preclinical work, both in my lab and in many others across the globe, basically it has been shown to decrease the size of infarction or brain injury from anywhere from 40 to 80%, and that multiple doses are better. They provide optimal benefit. And in rodent models, and sheep and other large animals, the neuroprotective doses range from 1,000 to 5,000 units per kilo per dose. Next slide. So to summarize, acute effects of EPO include decreasing inflammation, apoptosis, and oxidative injury, which all combine to improve cell survival. Next. These combine to long-term effects so EPO increases erythropoiesis and decreases free iron. It increases angiogenesis and also increases neurogenesis and oligodendrosis, which all go to increasing brain repair. Next slide. So how do we close the gap from rats to humans? That's the big question, because many things have been shown to be neuroprotective in rats, and it doesn't really translate to humans. Next slide. So to answer this question, we first looked at what the pharmacokinetics of EPO were in rats, and this was a study done by Pamela Statler. She looked at pharmacokinetics of both IP and sub-Q doses, and you can see the pharmacokinetic profiles here. Next slide. We then did a phase 1 study in human babies looking at 500, 1,000, and 2,500 units per kilo, and showed that the 1,000 units per kilo dose corresponded the best to 5,000 units per kilo in rats. So that is the dose that we moved forward with for future clinical studies. Next slide. So that brings us to the PENUT trial, which was a randomized controlled phase 3 trial. We enrolled 941 extremely preterm babies between December 2013 and September 2016. And these kids were followed through to 2 years, at which point neurodevelopmental assessment was done. Next slide. Our primary hypothesis was that early high-dose EPO plus maintenance EPO through 32 weeks corrected would decrease the combined outcome of death or severe impairment from 40 to 30%, measured at 2 years of age. And secondarily, if you included moderate neurodevelopmental impairment, we hypothesized that this would go from 60 to 40% at 2 years of age. And we estimated death to be 18% based on the current literature at that time. Next slide. Our inclusion criteria were inborn babies at our 19 sites and 30 hospitals between ages 24 and 28 weeks gestation. They had to be enrolled by 24 hours, and of course parental consent. And consent was pre or postnatally. And exclusion criteria were basically things that we knew would affect neurodevelopmental outcome. So here's our consort diagram. Next slide. So 3,200 babies were assessed for eligibility. We excluded 2,325 and randomized 941. Half were assigned to EPO and half to placebo. And basically we ended up with 79% of our babies allocated to EPO were followed within window at 2 years of age, and 79% of the placebo-treated babies. And you can see in these boxes how many babies died, how many babies were lost to follow-up. Some babies, about close to 3%, came in for follow-up, but we were not able to complete the exam. And about 5% in each group, the exam was conducted out of window. So this is the protocol for the, sorry, next slide. So we had 24 hours to enroll babies. After consent was obtained, we got a head ultrasound and a blood draw for EPO levels and circulating biomarkers. Babies got 6 doses of either EPO or placebo, and then they went to maintenance doses through 32 corrected weeks. A subset of babies had MRIs, and then after discharge, they were followed by phone at 4 to 6 month intervals. And then at 2 years of age, they had a standardized neurologic exam, a Bailey 3, and MCHET. Next slide. This is our classification system. We classified babies as severely impaired if they had a gross motor function classification score of 3 or greater. And if any part of the Bailey exam was scored at less than 70, and moderate impairment was considered cerebral palsy of GMFCS score of 2, and Bailey scores less than 85. Next slide. We use generalized estimating equations to account for the potential correlation of outcomes between siblings. We used a modified intention to treat per protocol, adjusted for site and for gestational age. Next slide. Here's our maternal demographics, and you can see there are really no differences. We had a nice distribution of maternal education, with about a third of patients having high school or less, a third some college, and about 25% college degree or greater, with a little over 10% not reported. Complications were similar by group, as were prenatal steroids and magnesium sulfate and cesarean section delivery. Next slide. This is the neonatal information at baseline. And again, there were really no differences between groups. Of note, we had about a quarter of the patients in each gestational week group, 26% twins or greater multiples, and really everything else was about the same. This shows the adverse, sorry, next slide. This shows adverse events that were pre-designated, so hypertension, polycythemia, because these were complications of treatment in adults. And then we included several complications of maturity. And you can see there are really no differences in these adverse events by gestational, by group. And that includes severe retinopathy of prematurity. And as you recall, this was a big concern going into this study. Next slide. Complications of prematurity are shown here. And again, you can see there's really no difference based on treatment or placebo, with the exception of there were fewer transfusions in the EPO-treated group compared to the placebo-treated group. And if you can just click through to the next slide. This shows our primary outcome of death or severe neurodevelopmental impairment at 2 years of age. And as you run through these, death was a slightly higher risk, but crossed 1, and so was not statistically significant. Neurodevelopmental impairment tended to be less in the EPO-treated group, but again, this crossed 1, and so it was not considered statistically significant. Cerebral palsy was quite low in both groups, with 2.6% in the EPO group compared to 5.7% in the placebo group. And overall, death or severe impairment was no different by treatment group. And you can see the results are broken down by gestational week here, and also by sex. And you can see there's really no difference. Again, and if you will click through these to the next slide. I did want to make the point that death or severe impairment was lower than predicted. We predicted 40% and saw 26% by group. Next slide. So clearly, this was pretty disappointing. We had spent years planning this trial, and with all of the preclinical work that was so positive, we were quite disappointed about this. We did show that high-dose EPO was safe, and that overall death, neurodevelopmental impairment was lower than predicted, based on the studies that were at the time. And again, we saw no difference in primary.
Is some kind of a T-bird stuff?
They just passed. They're coming right back down again.
Oh, yeah? I should drive mine.
I know, right?
Yeah.
You all.
Sorry. Please mute your lines.
Great.
Sorry for that.
Sure. So next slide. So what else could we learn from this study? Next slide. Well, we looked at IVH specifically because there's a hypothesis and an ongoing study suggesting that EPO might work specifically on babies who had intraventricular hemorrhage. And so on the left side of this slide, these are babies who had no intraventricular hemorrhage prior to study drug. And the dark blue shows death, the light blue shows severe neurodevelopmental impairment, and overall the results were identical by treatment group. And on the right-hand side, you see babies who had an IVH prior to study drug. So this occurred in 21% of our patients. And again, while early IVH does decrease the chance of death, it did not decrease the chance of death or severe neurodevelopmental impairment by treatment group. Next slide. We did see that transfusion rates were dependent on gestational age, and you can see here 3-day total of transfusions, and the 24-weekers had about 70% at the peak incidence of transfusions compared to less than 25% in the 27-weekers. Next slide. This shows transfusions of all study infants, and you can see that the EPO-treated children are in red compared to the placebo. And if you click on that one more time, you'll see that more EPO-treated babies were transfusion-free, so 138 versus 59. And that this was particularly true in babies who survived compared to babies who died. And so you can see in panel C, babies who died, the transfusion rates were identical, but not in panel B, where these are just children who survived. Next slide. So the number of unique transfusions were fewer in the EPO-treated group, and you can see here the relative risk is shown both for all babies, shown in the filled squares compared to babies who survived, and that was true at all gestational ages for survivors, and no difference by sex. Next slide. This, shows the cumulative volume of blood transfusions, and again, EPO is shown in red, significantly lower than placebo kids. Next slide. This is the cumulative volume, again showed by relative risk, and again, this was fewer or less in the EPO-treated kids. Next slide. This is important because in the past people have said the EPO is not worth using because it didn't decrease donor exposure, but we've shown here that it definitely does. So you can see, again, overall and by gestational age and by sex, it decreased donor exposure. Next slide. Despite the decrease in transfusions, hematocrits were higher in the EPO-treated children, and this was true at all gestational ages. The green vertical line here shows 32 completed weeks, so this is when EPO treatment was stopped, and you can see that the effect wanes over the next few weeks after discontinued. You can also see in this slide that the effects were greatest in the most mature babies. Next slide. This shows iron intake, and we did have a protocol for iron administration, but it was not, sorry, it was guidelines, not protocol. And so you can see that here on average, EPO treated children received more iron than the placebo-treated children, but it's actually what's normally recommended for babies that are treated with EPO. So when we clinically start EPO treatment, we start them with 6 to 9 milligrams per kilo of iron per day. And you see here that the average EPO intake for the EPO-treated, iron intake for the EPO-treated kids was a little less than 5 milligrams per kilo. Next slide. So unfortunately, that resulted in babies who were EPO treated having lower ferritin levels. And you can see on this slide, again, placebo treated children are shown in blue, EPO are shown in red, and the green dotted line shows ferritin levels of 75. And there is ample data showing that if your ferritin is lower than 75, you have abnormal brain conduction, and if it's lower than 40, there's severe developmental consequences. Next slide. So I'm going to just go down a little rabbit hole here for a second and talk about iron. 80% of iron transfer occurs in the 3rd trimester, so supplementation is essential. And iron is important for normal brain development. It's important for neurotransmitter synthesis, for myelination, for dendritogenesis. And this is a panel that was kindly given to me by Michael Georgieff. This is an experiment done in rats that were either iron deficient, shown in the upper panel, or iron sufficient. And you can see in this hippocampal slide that dendritogenesis is quite abnormal in these animals that had low iron. And we would like to avoid that in our human babies. So what factors influenced neurodevelopmental outcomes? Again, we're trying to get as much out of this study as possible. So we had 838 infants that were discharged alive. 715 were evaluated at 2 years of age. There were 9 late deaths after discharge, and 90 babies had severe impairment. So when we looked at SAEs and the increased hazard ratio for death, necrotizing enterocolitis appeared to be the most dangerous, and you can see there's a over 20-fold increase in hazard ratio, followed by pulmonary hemorrhage, sepsis, grade 3-4 IVH, or other SAEs. And this other SAE was primarily SIP, or spontaneous intestinal perforation. We next asked, if you survive these SAEs, how do they affect impairment? And so these are the demographics, and this is no surprise. So if your weight is, or OFC is less than the 10th percentile, you have a higher risk of developmental impairment. Hydrocephalus on the baseline ultrasound was also indicative of impairment. Next slide. But if you survived an SAE, it didn't necessarily mean that you would go on to develop neurodevelopmental impairment. So NEC, which was again the SAE most likely to result in death, it did actually increase the relative risk of impairment, but pulmonary hemorrhage and sepsis did not, nor did ROP, but grade 3-4 hemorrhage did, and again, SIP did. Next slide. When we looked at risk of impairment with number of SAEs, you can see in this graph that if you had no SAE, the risk of impairment was 7%. If you had one SAE, it was 18%. And if you had more than one SAE, it was 42%. So the number of SAEs really did affect impairment. Iron is a really controversial topic in neonatology, and there are people who are really super conservative about giving iron because of the concern of oxidative injury, and there are people who are less conservative, like myself, who follow ferritins or zinc protoporphyrins every 2 weeks to make sure that we attain iron sufficiency in this population, since we know it's so important for neurodevelopment. And we looked in our population here at dose of iron and Bailey scores at 2 years of age. And the first top panel shows cognitive, motor, and language at 60 days, with 60 days of iron, and you can see that the more iron you got, the better your scores were. And this was also true at 90 days on the lower panel. Next slide. Transfusions were associated with lower scores, and across the top here, you see number of transfusions, cumulative volume of transfusion, and donor exposures. And then on the left-hand column, you see cognitive, Bailey scores, motor, and language. And across the board, basically, the transfusions were associated with lower Bailey scores. Next slide. When we looked at any transfusion and Bailey scores, you can see here, again, this is cognitive, motor, and language scores in the 3 panels, and each one shows no transfusion, any transfusion, or in placebos, and then none or any in the EPO-treated group. And across the board, if you got transfused, outcomes were slightly lower. This is no surprise. When we looked at injury scores by on MRI, higher injury scores were associated with lower cognitive scores across all 3 components. Cognitive, motor, and language. Next slide. This is work that is just going to come out in the next, well, it's going to be submitted next week. This is work done by one of my colleagues, Mihai, and you can see that prolonged use of sedatives can worsen outcome. And first, at this top panel, what we show is the difference in use by center. And so this 19 centers are shown across the bottom, and either no use of opioids or benzodiazepines are shown, use of either, or use of both. And so the first purple panel shows that. The second blue panel shows just the use of opioids, and the third panel shows the use of benzodiazepines. So there's really quite a bit of variability across the country, across our sites in the use of these drugs. And then next, in the bottom panel, you can see that infants exposed to both opioids and benzodiazepines for more than 7 days did worse. And the estimated difference in their scores are shown here. So -6, -10, and -5 points on BSID scores for cognitive, motor, and language domains. So this is very significant. This slide shows a graph that we just came up with yesterday. And thank you, Mihai, for allowing me to show it. So this is exposure associations and BSID scores. And so I'll just walk you through it. The top one is any opioids, less than 7 days is short, more than 7 days long, morphine, then fentanyl, any benzodiazepines, midazolam alone, or lorazepam. And you can see there's very significant effects with the more prolonged use of these drugs. And this was adjusted for treatment category, for gestational age, birth weight, sex, multiple gestation, maternal education, maternal race, maternal hypertension, chorioamnionitis, prenatal steroids, tobacco, etc. So we really think that this is an effect of the drug, although because of the retrospective nature of this this analysis, we can't guarantee that for sure. This is another project that's sort of fun. Basically, we're looking at the use of antibiotics and the incidence of infection. And we're just starting to delve into this here, but the black lines show antibiotic treatment, and the blue dots show gram-negative infections, the red dots show gram-positive infections, and the black diamonds show death. And just what you can see here at a glance is the disproportionate use of antibiotics compared to infection, particularly in the first week of life. And so, again, this is our brain group, and I'll show you the folks that are in that in my closing slide, but are looking at and interpreting this. And I think this speaks to the efforts about antibiotic containment, basically. Lastly, we have another group looking at resource use, and this is led by our San Antonio group. And basically what they have looked at is the use of early intervention, physical therapy, occupational therapy, speech therapy by state and demographics. And you can see on the left-hand panel that it differs quite a bit by state, and with Massachusetts leading the group, and it also differs by maternal characteristics, with age showing increased use with increased age, but also differences by what the child's problem is. And so this is something that we're looking into more, and so stay tuned for publications that will be coming out about this. And I think the bottom line is that outcomes are the result of interactions between many different factors. And so to start with, there's the prenatal factors with gestational age, fetal growth restriction, whether or not you get prenatal steroids, whether mom is iron deficient or not. Then there's the comorbidities that occur. So whether you have BPD, ROP, NEC, etc. The treatments that you receive during your stay. So for example, the sedatives that we discussed and transfusions. And I think as you go home, the chronic health conditions that these children have make a difference, as well as the resources that the families have in dealing with these chronic health conditions. And so what we hope to do in a follow-up study that we hope will be funded is look at neurodevelopment at 8 years, taking into consideration all of these things, the chronic health conditions, and also looking at how these extremely preterm infants do as they age. There's more and more data coming out about things like hypertension and chronic kidney disease and so on. And so we hope to be looking at that as we move forward. Next slide. So I can't say enough to thank involved in this study. And so this is a picture of our PIs at the last PIS meeting that we actually went to in person. So we thank all of them and the coordinators without whom this would not have been possible. Our DCC is led by Patrick Hagerty, and Brian Comstock has done the yeoman's work on doing the statistical analysis. And the brain team is shown here, and these folks are helping us to go through all of the data. We have over 5 million pieces of data from this study and write some interesting papers as a result of this study. So thank you so much, and I'm happy to take questions. Next slide.
Thank you so much, Dr. Juul. All right, so let me see if we have any questions from the audience.
Can we have should we read the question, or I can just ask the question?
Yes, yeah, I'm reading the questions. Yes.
Okay. So Dr. Juul, while Dr. Karnat is reading the questions, I just have a question or maybe a comment. It's excellent presentation, of course. This is Hani Ali, and I really love your presentation. The question is, the premature infant has continuum of stress. You even have delineated some of them, such as a stressful event, use of sedation. There are so many things. So it is very hard to think that one drug like erythropoietin will really eliminate all these complications. So the result is kind of expected. But now, how can we make use of erythropoietin, knowing that it does work in full-term baby, it does work on animals, and we couldn't show differences in premature babies because there are so many stresses they face. So should we start using erythropoietin regardless?
Yeah, that's a great question. So I think we've definitely shown that it makes a difference for transfusions. I think because of the iron deficiency that was so prevalent in the EPO group, we can't really say whether EPO would have worked if the babies had been iron sufficient. That remains an outstanding question. We are currently in the process of doing a cost effectiveness study to see whether using EPO in this way and decreasing transfusions is cost effective. But I think unfortunately, we did not show that EPO was neuroprotective in this group. And I would caution you in saying that it's protective in term infants because we are in the midst of that trial. So the HEAL trial has completed enrollment of 500 babies, and we have about a year left to finish the 2-year evaluations.
Thank you, Dr. Juul. So there are a few questions from the audience. So one asked about the hematological findings of the study Not sure that exactly. What is the definition of unique transfusion? What is unique transfusion in that you mentioned?
So it's each individual transfusion. So if a baby gets 15 per kilo, 15 cc's of blood per kilo, that's considered one transfusion. And the reason that we called it out that way is because many centers aliquot blood. And so for one unit of adult blood, as many as 8 transfusions can be given. And this varies from site to site. So we looked at, and that's the reason we looked at individual transfusions, cumulative blood, as well as donor exposures.
Okay. Thank you. Did you look at if EPO decreases the extension of IVH? If so, what is the mechanism of that?
Yeah, it did not. That's another study that I didn't have time to go into, but we've looked extensively at the timing of IVH as well as the effect of EPO. And EPO does not affect extension of IVH.
Okay. I think you mentioned about reducing the transfusion needs. That answered already. For opiates and benzos and the NDI, did you also adjust for NEC as a confounding factor?
No, I don't believe so. Although,
Okay.
Mihai, I think you're on the talk. Do you want to unmute yourself?
Hi, can you hear me? Yeah, we didn't control for NEC specifically, but we did take out the 3 days post-op for any surgical procedure.
Right. Thank
Okay.
you.
Is combining EPO and other potential intervention like melatonin, is this something can be applied?
Well, there's a lot of interest in melatonin, mainly for HIE as opposed to preterm brain injury. But I have seen some proposed trials looking at perhaps oral melatonin or IV. I know Nikki Robertson is very interested in this area, and I think is sort of leading the way in this melatonin field.
Yeah.
Again,
Yeah.
the comment earlier about the duration of stressors in preemies is really important. And if you think about all of our animal models, they're really acute models, right? Even if they're models in preterm animals or preterm equivalents, there's no way of really modeling the day in and day out pain, stress, the bells and whistles that are going off with the alarms, being away from your mother, all of the stuff that's happening in the NICU, it's really impossible to replicate that in an animal model.
There are a couple of more questions on delayed cord clamping. I think you mentioned, did all the babies in your trial got delayed cord clamping? I think it looks like 40% each.
Yeah, it was about 40%.
Yeah.
It was, this trial started a while ago, and it was just during the period where people were trying to get this to happen more consistently in their units.
Okay, yeah. That's a question is whether that could have confounded delayed cord clamping, but it's equal.
Yeah, it was the same in both groups.
Yeah. What method was used to determine the severity of the brain injury on the MRI? What scoring? So
we use the Kitakoro grading system. So this is from Terry Inder's lab. And basically there's a bunch of criteria in different parts of the brain, and each area is scored, and then the score is added up, and that gives you your injury score.
Okay. The composite outcome for death and NDI is better than placebo, but it looks like it is mainly driven by the larger gestation babies of 27 weekers.
Yes.
comment.
That is true. And, you know, I have to wonder whether that's because they were iron deficient for less time. I don't know the answer to that, but I can speculate. And of course, you know, at this point in time, it's very unlikely we'll be given another $10 million to repeat the study with iron sufficiency guaranteed. So that's unfortunate.
Yeah. Transfusion is a possible risk factor for IVH. Was it corrected for?
Say that again.
Transfusion, blood transfusion is a possible risk factor for IVH. Was it accounted for?
I don't believe that came up as one of our, when we looked at risk factors.
Mm-hmm. And similarly, sicker patients got more sedation. So how do you control for that? That's the other question from other.
Yeah, well, that's a great question, and we did try and control for as many things as possible. That's why I read off that whole long list. It's a propensity score for bad outcome, and of course, you know, we can't. This wasn't a randomized trial to look at these sedations, medications, so that's a limitation of the study. But one of the reasons that I spent time talking about the variation by site is to show that we as neonatologists, we really do use these drugs differently, and despite that, we saw these results. So.
Okay. Another question, how would you explain that high iron and hemoglobin is good to brain while transfusion is associated with bad outcomes?
Great question. I think it's important to recognize that there's more in the transfusion than iron and red blood cells. So it's well known that transfusions are associated with an inflammatory response, and it's possible that inflammation is contributing to a poor outcome.
Okay. Practice of doing ferritin in growing preterms who are on iron supplementation. Are there any guidelines or for these who are on iron supplements?
I'm sorry, you're asking about guidelines?
On ferritin, I think the levels of ferritin, checking ferritin levels on these. So do you follow any?
Yes, we do. We check ferritin levels every 2 weeks, as well as zinc protoporphyrin to heme ratios. And we adjust the iron dosing that we give our babies, and we give babies up to 12 milligrams per kilo per day.
Is there any role for darbepoetin, the long-acting erythropoietin?
Well, there's certainly a lot of interest, and there's an ongoing study looking at whether darbepoetin is neuroprotective in this group of babies. So there's less preclinical data about darbepoetin, but potentially it would also be protective.
Okay.
Can you hang on just 1 second?
Sure.
Can you just hang on? Okay, I'm back.
Again, the combination, the neuroprotective therapies, other than the melatonin and the EPO, are there anything coming up in future? Anything being studied?
Well, I think, you know, there's many drugs that people, all these labs, people who are interested in working in neuroprotection for preemies have their favorite drug, right? So one candidate is azithromycin, and John Barks has shown very nicely in a rat model that that's quite neuroprotective. Melatonin is another one. Vitamin E is another one. There's yes, there's many, and I think you know, trying to develop models that are truly useful to study these drugs in is really a critical lack.
Okay.
So we're working on that. My lab recently developed a ferret model of preterm brain injury, and Tommy Wood has led that effort, and we're hoping that that will be a translatable model.
Okay, great. Can you share more about in therapy service delivery? That's use of resources across the states. Were these therapy services in the NICU, or did you look at the variation across the level of NICU? There are multiple questions actually here. But
Yeah. So this was post-discharge was what we were looking at, not within the NICU.
And there was variation across the.
Yes. So that was very interesting. It really, now we can't say for sure that this was state by state, because it's like for most of our units, there was only one NICU in that state, but there was definitely regional variation, and in all of the areas. So we looked at early intervention as well as physical therapy, occupational therapy, speech therapy, etc. I don't know if Kashif is on the line here. If he is, he could unmute, but I don't actually see him in the list. But I think that's a very important aspect, and we have one paper that is going to be submitted this week, and then the second paper will be to look at whether that intervention makes a difference.
Okay. Did you consider breast milk use in these groups? Like, was there any impact on the breast milk?
We did not look at breast milk.
Okay. All right. I think those are the hematological findings of this trial published anywhere?
Yes, they are. They are published in JAMA Peds, and then there's another paper that's accepted in Peds Research looking, so the initial findings were published in New England Journal. The findings specific to transfusions were published in JAMA Peds, and the neurologic outcomes and transfusions will be coming out shortly in Pediatric Research.
Okay, wonderful.
So thanks everybody for staying late, and
Thank you.
so that we were delayed in starting due to technical difficulties.
No worries. Thank you so much. It's really wonderful. Actually, it's a great talk, and thank you so much for your time. And happy holidays. Stay safe.
Likewise.
Thank you, Sunny.
Bye.
Thank you, everybody.
Thank you, Sunny.